Hello, this is Dr. Gay from First Look MRI, and this is a 69-year-old male who had a history of injury several weeks ago, falling injury. Now has wrist pain, most pronounced on the ulnar side. This is a wrist arthrogram, and when I did the arthrogram, nowadays I inject over here, right about here, near the distal radius, but slightly more distal, and I come down to hit the scaphoid bone right there, and they seem to do pretty well and have the palm down, and so this part of the wrist is pointing upwards, so the palm is in flexion. That really opens up that dorsal joint, and that seems to work a lot better than when in the olden days I used to go right here, and sometimes it wouldn't work. Never could figure out why, but since I've been going here over the past 10 years or so, I've had really good luck. So this patient has contrast in their proximal carpal row, and we're looking for that triangular fibrocartilage. Now, if you don't see TFCC tears very often, this can be really daunting. If you see it once a month, you always get nervous because you don't know the anatomy and don't have a good feel for normal versus abnormal. So I'm just going to show you this quick example of an obvious tear that hopefully will be helpful. I always start out by saying if the ulnar variance is neutral or positive or negative. So the ulna should be a little bit proximal to the distal radial articular surface. This is kind of borderline. It's slightly more distal than I'd like it to be, but it is about within normal limits. For any further, it's a positive ulnar variance, which means there's not much room for the TFCC to go through there. And when they have that, the ulna can abut the lunate bone here and pinch that TFCC. And again, this is right at that borderline. It may be slightly more positive than it should be. And negative ulnar variance is when it's down too low, then there's abnormal stress between the radius and lunate, and they can have degenerative changes and marrow edema at the base of the lunate bone. But this is roughly neutral, if anything, slightly minimally positive. And now we're going to look for that TFCC. So we can see that there's fluid contrast we've injected over here in the distal radial ulnar joint, so we know that there's a problem. The TFCC is torn, and we're going to look for that on this gradient echo sequence. Now in this sequence we can see fluid in the distal radial ulnar joint. Here's the radius, ulna. This is actually contrast here. And right here in between, we should see at the midpoint the central disc. It's just a little cartilaginous area, central disc, and we do not see that little fibrocartilaginous area band. We see fluid going right up into it. Along the top of it looks like it may be intact, but along the undersurface it looks like there's definitely a tear. So it looks like a high-grade tear, partial thickness, along the undersurface of the central disc. If we go one cut along the palmar aspect, this is the palmar band. Now we're into that central disc that's torn. We're going to go into the dorsal aspect. Here's the dorsal band coming off the radius. So those palmar band and dorsal band look like they are intact. And then over here we have a couple attachments. One comes down to this little cupped area. That's the foveal attachment. It looks like that is torn, and the TFCC comes over here and drifts upward rather than downward into this. And this is the styloid process. It looks like the TFCC is torn from the styloid process. So in this I'd say there's a high-grade partial thickness undersurface tear, the central disc, the dorsal and volar bands look within normal limits, and then the TFCC is torn and uplifted from the foveal and styloid attachments. Contrast is allowed to go down here into the distal radial ulnar joint. And this is the money shot. This is the T1 fat suppressed sequence. Now we can see contrast was injected over here to the proximal carpal row. Contrast is undermining here where the foveal attachment is and where the styloid attachment is. It comes down across. It comes down here. It looks like it's also coming proximally beyond the distal radial ulnar joint here. And we're looking at this one last thing. Here's that palmar band, central disc. It's super, super thin. It could be a little full thickness perforation there. Just can't quite see it. Maybe related to slice selection, but this should be really thick right here. Almost as thick as this, but it says it's very thin. And we go to the dorsal band coming across here. So that's it. A tear of the central disc. That's full thickness or near full thickness. And the styloid and foveal attachments are torn and uplifted. And there's fluid in the distal radial ulnar joint. And they also had a little injury over here. The ulnar collateral ligament complex over here is torn from the triquetral bone here. The cortical irregularity you can see on this view as well. And this is sort of an unusual injury. I always look out here at these ligaments to see if they are thin or thickened, but here it's clearly thickened, clearly bony changes. So they've had a little avulsion or cortical and periosteal avulsion injury over here, which again is pretty rare. And one last look at that. It's that marrow edema and cortical irregularity. And that's it. Hopefully that helps to go over the anatomy again, and hope you have a great day.